Good afternoon, everyone. A warm welcome to today's session of Cuddles Online Neonatal Education. In today's webinar, we will discuss about the respiratory distress in neonates and X-ray interpretation of the same and some case-based scenarios and OSCEs regarding the same. So since X-ray is the most commonly used one in NICUs, like in every in smaller setups also, we use X-rays day in and day out. So I have included a few X-rays and cases which we have treated at KIMS Cuddles Kondapur and discuss about the X-ray interpretation of these cases and the different neonatal respiratory conditions. Now the upcoming modality is neonatal lung ultrasound. So that has also been discussed in our previous webinars. Today we will see about the X-rays. So let's move on. So like coming to the interpretation of X-ray. So whenever we are reading an X-ray of a baby, so we should go in a following order. So first we should see whether the projection of the X-ray is AP view or a PA view. So like usually in neonates, the X-rays are taken in the AP view only because the baby will be in the supine position and here you can see the X-ray. So and then we have to describe it, the rotation of the X-ray. So this we generally tell based on the orientation of the clavicles, and the clavicle should be equidistant from the midline and the alignment of the ribs. And also the vertebrae. So by that we can say if that is the rotation is proper, or if it is like baby is rotated to one side or not. And also the projection, we will say whether it is an AP view or a PA view. So the PA view, like in that the scapula will be more visible, and so that is generally done in bigger children. For neonates, we are preferring the AP view X-ray only. And then inspiratory film and expiratory film. This is difficult to tell in a neonate. In expiratory film, the domes of the diaphragm will be flattened, but in babies, most of the X-rays will be in expiratory only, because the neonates spend a majority of the time in the expiration. Then we should comment upon the exposure of the X-ray, whether it is underexposed or overexposed or adequate exposure. So if it is like adequate exposure, means we should be just able to see the vertebral bodies against the silhouette of the X-ray. So if it is underexposed, we will not be able to see the lungs, aeration in the lungs properly. And if it is overexposed, then it will be like too much dark on the X-ray. So then also it will be difficult to interpret the X-ray. Then we should also comment upon the soft tissues. Sometimes soft tissues shadows are also seen on the X-rays, which can get confused as the air leak or pneumothorax. Then we will comment about the bones, vertebrae, ribs, clavicle, and note if there is any fracture or any signs of like osteopenia of prematurity. We will just see the density of the bone. And we will also see the lung expansion and pathology. Normally it should be around the expansion should be around 6 to 8 spaces in a baby, and we will comment upon the pathology, like if there is any collapse or consolidation, or like RDS changes, TTNB changes, meconium aspiration changes. So many things we can know based on the X-ray we are looking at, and also BPD changes. So these are the different common pathologies which we can comment upon just by looking at the X-ray. And we will also comment about the cardiac size and cardiothoracic ratio. So cardiothoracic ratio, like it's measured like a line drawn in the midline of the baby, and from the midline to the apex of the heart, and then the maximum distance on the opposite side, which is divided by the overall the length of the like the rib cage. So it should be like if it is more than 0.6, then that indicates that the cardiomegaly is present. And also we should comment about the mediastinum, and also any lines and tubes which are seen on the X-ray, and the airway, trachea, and sometimes the bronchi are also seen, and also the alignment of the diaphragm. So these are the common things which we can comment whenever we are looking at the X-ray. Now let us move on to the case-based scenarios or OSCEs. Here I'll be showing the some cases, interesting cases which we have treated at KIMS Cuddles Kondapur. So this is a twin to late preterm baby who was born by emergency LSCS in view of PPROM in the mother. The baby's birth weight is around 2000 grams. Baby had severe respiratory distress soon after birth, so needing mechanical ventilation. And X-ray was done, which was suggestive of grade 2 RDS changes. So like when you are grading the RDS on X-rays, so normally we will grade it like grade 1, where there will be a low volume lungs and minimal reticulogranular pattern, and grade 2 will be like the moderate reticulogranularity, but we can see the cardiac border clearly, like here in this X-ray, and also a bell-shaped thorax will be there. And in grade 3 RDS, there will be like increase in the reticulogranularity, which obscures the cardiac borders also. And in grade 4, that will be a complete whiteout of the lungs. So grade 4, we don't generally see nowadays, because the mothers are usually covered with antenatal steroids, and the babies are also started on delivery room CPAP. So we will see either grade 2 or grade 3 in most of the cases. And for this baby, in view of grade 2 RDS changes, 1 dose of surfactant was given. Then subsequently, the baby was planned for extubation at 24 hours of life, since the baby was on ventilator with minimal settings. As soon as the baby was extubated, the baby had a severe respiratory distress with desaturations. What could be the differential diagnosis in this case? So the possibilities which we considered were like early onset sepsis or unresolved RDS or any airway related changes. So then like the nasogastric tube was tried to pass. Baby also had like more of upper airway kind of retractions, which could not be passed. This tube could not be passed through both the nostrils. Then subsequently, choanal atresia was suspected for this baby, and the CTPNS was done, which confirmed the same findings. So then the baby had to undergo an ENT evaluation. So whenever you are having a case of like baby is having distress which is not improving with the regular treatment, and you have already treated for RTS, baby is not looking like sepsis, we should think of the airway causes also. So neonates being preferentially nasal breathers till 4 to 6 weeks. So now we will see like a few questions, like what are the boundaries of the posterior choanal aperture. So the under surface of the choana is formed by the sphenoid, its upper surface is formed by the under surface of the sphenoid bone, medially by the medial pterygoid plate and vomer, and below by the horizontal surface of the palate. So these are the boundaries of the posterior choanal aperture. The incidence of choanal atresia is 1 in 5,000 to 7,000 live births. And the associated anomalies for this are Church syndrome, like we have to rule out other anomalies like coloboma, heart defects, atresia choana, restriction of growth and development, and genital anomalies and ear anomalies as well. So whenever we have a baby with choanal atresia, we should do the same. So what will be the presentation in these babies? So if it is a unilateral choanal atresia, the presentation might be delayed as well. But in bilateral choanal atresia, usually the babies present a little early with respiratory distress, cyanosis, failed extubation, choking on feeding, and the distress which relieves on crying. These are the common symptoms which we see in choanal atresia. So unilateral atresia presents with chronic nasal obstruction, rhinorrhea, and sinusitis. So this we can suspect in the slightly bigger babies who visit our OPDs. So how do you evaluate and treat? It will be obviously a surgical management by ENT surgeon. So where we have to do the nasal endoscopy, and surgery will be by the drilling of the atretic plate and creating a mucosal flap. This baby was treated with the same, and the baby could be successfully discharged around 1 week later. And the risk factors for recurrence, so some of them might come back with the recurrence also. That could be due to these risk factors, like the baby being presenting with age less than 10 days and having a complete bony obstruction which required extensive drilling, and endoscopic techniques, baby is having any reflux or any other malformations. So, but otherwise, the post-operative stenting is also controversial in these babies because there have not been much studies which prove that the stenting will prevent the recurrence in these babies. So this all these points we should keep, we should know for our knowledge. So then we will look at the neonatal upper airway anomalies. So like in the nasopharyngeal wise, so the babies can have this pyriform stenosis, nasolacrimal ductuses, and tumors. And oral area wise, the syndromic babies might present with oral anomalies like in Perry-Robin syndrome, Treacher-Collins syndrome, Down syndrome. Down syndrome babies can also have the hypotonia and poor latching and suck. Then, so that might present with some airway related issues. Coming to the laryngeal lesions, so it has been divided as the lesions which are in the supraglottis, glottis, or subglottis. So, the common ones which we see are laryngomalacia. This is the most common anomaly seen in neonates, and vocal cord paralysis, particularly in the babies, post-surgery babies. Sometimes we see, and laryngeal web cleft and um, congenital high airway anomaly. So this case also is a very rare condition, sometimes seen in babies. And coming to the subglottic anomalies, subglottic hemangioma, stricture, and intubation trauma are anticipated. So that is about the first case of choanal atresia. Next, coming to a baby who presented with a like at the age of 28 days with a birth weight. Baby had a birth weight of 2.5 kg. Current weight is 3 kgs. Like now, by around the baby should have had a slightly more weight gain. Baby is having a slightly lesser weight gain because the baby always used to have the cough, noisy breathing, and recurrent episodes of vomiting. So that was the complaint given by the mother. The baby also had a suprasternal and substernal retractions. Baby is otherwise doesn't have any signs of infection like no fever, decreased activity, or decreased feeding. All those were not there. Only thing is the noisy breathing, vomiting, and cough is persistent for the baby, along with a mild decrease in the weight gain. So I'll just play the video of the baby. So here you can see the like classical audible stridor, which we see in babies who are having the upper airway problem, like the ones which we previously described, the laryngeal lesions, like either supraglottic or glottic. So usually the glottic and subglottic, they can present with both inspiratory and expiratory stridor. Supraglottic lesions present with the inspiratory stridor. So this baby is obviously having audible inspiratory stridor along with suprasternal and substernal retractions. So this kind of picture points towards the upper airway anomaly rather than the parenchymal, lung parenchymal lesions, which present more with the intercostal retractions and tachypnea. So in that way, we can differentiate the area of the pathology in the baby. So this baby, the diagnosis was like laryngomalacia. So what is the next step in the evaluation and management? Here you can see the the sagittal view of the airway of the baby. So here once you can see here the when we see the vocal cords, the vestibular folds and vocal cords, these are bounded anteriorly by the epiglottis above the hyoid bone and thyroid cartilage. So whenever this epiglottis is either too flappy or periepiglottic folds are too floppy, and they tend to collapse into the vocal cords when the baby is trying to take an inspiration, then that time the laryngomalacia will present. So for this baby, the next step of evaluation done was microlaryngobronchoscopy, and the baby was diagnosed to have a severe laryngomalacia. So the treatment for the same would be the supraglottoplasty. Obviously, in this, there are like many different like techniques and methods which are available. So once you suspect a baby as having a laryngomalacia, so we should take an ENT surgeon opinion and then proceed further. So this baby post that procedure, the baby's stridor and all disappeared. The baby became very comfortable and we could discharge the baby on direct breastfeeds. Coming to the anatomy of the neonatal larynx, The larynx in neonates is slightly different than older children. So in the way that it is situated a little bit up and anterior around C4 cervical vertebra, and it helps in the respiratory modulation, airway protection and voice production. So whenever there is any problem in the larynx, we will hear the obviously the coarse inspiratory stridor. If it is a glottic or subglottic lesions, we hear the biphasic stridor, which can be auscultated in minor cases, and in severe cases, it can be audible as well. So, coming to the congenital laryngomalacia, this is the most frequent cause of stridor, and we can see the prolapse of the poorly supported structures, that is the arytenoids, epiglottic folds, and epiglottis during the inspiration. So, we have to watch for cyanosis, hypercarbia, feeding difficulty, and failure to thrive. If there is a failure to thrive and feeding difficulty, then we have to intervene. Otherwise, mild cases resolve by around 12 to 24 months. In severe cases, the children may present with periodic apnea or cor pulmonale or pectus excavatum also. 20% will need the supraglottoplasty of all the cases of laryngomalacia. So this is the video of the same baby when we are doing the when our ENT surgeon is doing the procedure. So you can see the floppy epiglottis, which is the collapsing just before the, I'll display it again. So whenever the baby is breathing, you can just see the collapsing nature of the epiglottis. So that will be fixed by the supraglottoplasty. So, coming to the third interesting case that we dealt with. So this is an early term 37 plus 5-weeker baby with a birth weight of 3.3 kgs. So male baby. Baby was delivered by LSCS elsewhere in view of fetal bradycardia. The mother was had a marital life of 3 years, and she had a third degree consanguinity. She had gestational diabetes mellitus during pregnancy with otherwise normal antenatal scans. There was a previous death in one sibling. On inquiry, that baby was also like having some breathing difficulty, after which the baby has died. More than this, the attendants could not give any further information regarding the baby's condition. So the current baby was also having the respiratory distress. Initially, the differential diagnosis that we considered were like transient tachypnea of newborn or term RDS, since the infant being the IDM baby. And in severe case, like the other rare diagnosis which we can think of are pneumothorax if the distress is not settling despite providing adequate respiratory support. And X-ray will show us the congenital pneumonia picture is there or not. And we should also suspect early onset neonatal sepsis in a baby who is having respiratory distress. And if these above causes are not there, then we should suspect a cardiac cause also, either PPHN or critical congenital heart disease. So this baby, as the distress worsened, they have shifted from non-invasive ventilation to mechanical ventilation. 2D echo, of course, was done to rule out the cardiac anomalies, which was normal. Antibiotics started for suspecting early onset sepsis, but the cultures came sterile and there was no shock. So, suspecting the term RDS in view of the gestational diabetes in the mother, one dose of surfactant was given. Baby was continued on ventilation, and they could extubate the baby, and the baby was on non-invasive ventilation till day 11. But however, the baby was like not weaning out of non-invasive mechanical ventilation. The baby continued to remain on high NAMV settings and on prone nursing, and we could not wean the baby because there was like severity of the retractions were more, and the baby will desaturate if the settings were brought down. So subsequently, the ultrasound chest was done, which showed multiple coalescing B lines with few areas of irregular pleural lines. Possibilities included like only respiratory distress syndrome or underlying infections. Infection being adequately treated by such a persistent respiratory distress in a baby. So then we had to evaluate subsequently with a CT scan, which showed diffuse ground glass opacities in both the lungs with background septal thickening and mild dilatation of the bronchi. Then we suspected the possibility of the congenital surfactant deficiency in the baby. So then the genetic workup was done in view of the previous sibling death who also died due to the respiratory distress only. We suspected congenital surfactant deficiency, and the whole exome sequencing for this baby came positive for ABCA3 gene mutation. So This is the gene which is seen in the pathway of the surfactant metabolism, and this gene mutation is inherited in an autosomal recessive manner. Um, so the reason for this, the attenders, they had to withdraw the baby because the baby could not be weaned out of the non-invasive mechanical ventilation support. So now we will see what is the surfactant composition. So surfactant is made up of the phospholipids, saturated and unsaturated phospholipids, and lipids and phosphatidyl and also surfactant proteins SPA, SPB, SPC, and SPD. The surfactant is stored in the type 2 alveolar cells within the lamellar bodies, and it is excreted usually by exocytosis. ABCA3 is the short form for ATP binding cassette transporter A3, and it is critical for the proper formation of the lamellar bodies and the surfactant function. So any gene mutation of the same can lead to the surfactant deficiency, so which can be suspected in babies who are difficult to wean out of the respiratory support and having the RDS like picture. So coming to the next case, this is a very preterm 30 plus 3 weeks baby who was born with a birth weight of 1020 grams by LSCS in view of preterm labor in the mother. So the history of the mother being she had a chronic leak with a PPROM from a long time, and she had a chronic oligo with an AFI of 2 centimeters. Steroids were covered in the mother, and the baby was then delivered after proper steroid coverage. So the baby needed mechanical ventilation soon after birth and was given 1 dose of surfactant, Curosurf, after delivery, and the baby was continued on mechanical ventilation. So on day 2 of life, when we were thinking of extubating the baby had recurrent desaturation. So the first approach for a baby who is desaturating on mechanical ventilation is the approach is dope. So tube displacement was not there, tube obstruction was also not there. Ventilator was also delivering adequately, and when we checked for the transillumination, it came positive. So then the baby was having the right pneumothorax. So this is a risk in babies who are born out of the chronic oligo and PPROM. In them, they tend to have the lung hypoplasia. So this was the X-ray of the baby. Here you can see the clearly the border of the right lung over here, and we can see the pneumo above the right lung. So then ICD was placed, post which the baby is improved, and then the baby could be extubated after another 2 days. So pulmonary hypoplasia is the incomplete development of the lung parenchyma leading to decrease in number of distal airways, alveoli, and associated pulmonary vessels. So this is of two types, primary and secondary. So the pulmonary hypoplasia occurs secondary to oligohydramnios in babies who had renal anomalies, prolonged amniotic fluid leak for the mothers, and history of IUGR. Though this hypoplasia can also occur secondary to the space-occupying lesions such as CDH, CCAM, and cardiomegaly. And if the diaphragmatic movement is not proper, like in neuromuscular disorders, diaphragm eventration and phrenic nerve palsy, then also the babies are prone for the pulmonary hypoplasia. So this we should keep in mind whenever the baby is born out of the chronic oligohydramnios. So the pulmonary hypoplasia component should always be kept in the mind. So coming to the next case, this is a full-term baby who was born with a birth weight of 2.68 kgs by LSCS. Baby cried immediately after birth. There were no maternal risk factors. Baby had respiratory distress on CPAP also, so with desaturations. Then the baby was ventilated. So this is a term baby with no maternal risk factors, no risk factors of early onset sepsis as well. So TTNB needing ventilation and all is unlikely. And the baby did not have any features of um, pneumonia on the X-ray, no features of sepsis. Instead, the X-ray showed the reticulogranular pattern. So then subsequently, the baby also developed shock and poor perfusion with desaturations, had to be started on dobutamine. This is the typical history of a baby who is having the critical congenital heart disease. That is the TAPVC. So baby is having desaturations, shock, and X-ray showing the RDS like picture, we should always think of the TAPVC, and then the echo should be done immediately to rule out the same. 2D echo was done, which confirmed the diagnosis. The baby was operated, and post-operatively, the baby was continued on the mechanical ventilation. So coming to the X-ray approach in the suspected CHT, so we can note down certain points whenever we are commenting about the size of the heart and the position. Position, we should comment whether it is a dextrocardia or a levocardia, and the cardiac size we should be ratio should be less than CT ratio should be less than 0.6, and cardiomegaly, that is ratio more than 0.6, is seen in conditions like Epstein's anomaly, pulmonary atresia with intact VSD and TR, and any infant of diabetic mother, pericardial effusion, and severe anemia. These are the causes of cardiomegaly. And we should also look for the situs inversus whenever a suspected CHT case is there, and we should look for the cardiomediastinal contour. So normally the border of the heart, right border of the heart, is formed by the superior vena cava, as you can see here, superior vena cava from above, and then the right border is formed by the right atrium. So the left border of the apex is formed by the left ventricle, then it is continued by the left ventricle on the left side, followed by the left atrial appendage above the left ventricle. Then comes this bulge of the main pulmonary artery, and above that we can see the aortic arch. So this is the borders of the heart, which we all should be aware of. And we can also comment about the pulmonary blood flow, whether there is any pulmonary congestion on the X-ray or oligemia on the X-ray. Some of the characteristic chest X-rays in suspected heart disease are boot-shaped heart is seen in tetralogy of Fowler, Agon-side appearance is seen in TGA, and snowman figure of 8 is seen in TFABC. So these are some of the common X-ray findings. When we see the respiratory versus cardiac, so in the respiratory causes of distress, so the tachypnea and retractions will be more, but in cardiac, more than the retractions, the silent tachypnea will be there. And in respiratory, the desaturation is due to impaired oxygen transfer and ventilation perfusion mismatch, and the cyanosis improves by increasing the FiO2, whereas it does not happen in babies who are having a congenital heart disease. X-ray will be showing the lung features in the respiratory causes and cardiomegaly and the different shapes that we have mentioned in the cardiac causes. So if we do the lung ultrasound, we can see the double lung point, RDS, we can do an RDS score, we can see the features of pneumonia in babies who are having the respiratory causes, and we can also see the features of meconium aspiration. So, but in this one, cardiac causes, we can see the CCF features like hepatomegaly and shock. So these are some of the common differentiating points between respiratory and cardiac. Of course, the history and the clinical history plays a major role in coming to the proper diagnosis for the babies. So this baby post-operatively, the myocardial function slowly improved. Baby was extubated to NAMB by day 7 post-op. Feeds were initiated and then increased as per protocol. Baby reached full feeds. By day 11 of life, the baby had increased work of breathing. So then the X-ray was done, which showed like increased like pulmonary congestion and bilateral increase in the haziness, and we can also see the obliteration of the costophrenic angle. Then we suspected the pleural effusion for this baby, and we suspected like secondary to any thoracic duct leak or injury. So then the USG chest was done to confirm the diagnosis of pleural effusion. Around 100 ml of pleural fluid was noted on ultrasound, and then the ICD was placed because the baby had increased respiratory distress needing intubation again. And the fluid was sent for analysis, which showed the elevated triglycerides and LDH and cholesterol. So that fluid analysis was suggestive of chylothorax, and the baby also had a pericardial effusion. This happens in one of the post-operative complication of the cardiac surgery babies. So then the baby was kept NPO and later restarted on MCT based formula, which helps in cases of these chylothorax. So slowly the baby had a resolution of the chylothorax, and the baby could be extubated again and brought back to the room. So this is the video of the pericardial effusion. Here you can see the border of the heart, and surrounding the border you can see some space where there is the effusion. So normally this gap is not seen, like it will not be seen separately. So you can see in the four chamber view of the heart, you can see the just outside the like left ventricle, you can see some like hypoechoic area where the pericardial fluid is accumulated. So that was also like if it is in severe category like me going into cardiac tamponade and all, we have to drain that the pericardial fluid so that the baby's distress, desaturation, and shock will come down. So next, moving on to the case 6. Here, like we can see the X-ray AP view of the baby. What can we appreciate from this X-ray? What is abnormal here? So here we can see that the OG tube is not able to pass into the stomach, and we can see the coiling of the OG tube here. It is clearly visible in this X-ray. So this baby was referred like for increased frothing from the mouth and respiratory distress. This is a term baby who cried immediately after birth. Then the baby had a respiratory distress with excessive salivation from the mouth. So the baby was started on the CPAP and OG was placed and X-ray was done. X-ray was suggestive of this coiling of the OG tube in the upper esophagus. So on examination, the baby also had an absent anal opening. So what could be the diagnosis? It's a case of tracheoesophageal fistula. So in this important maternal history to be noted is the polyhydramnios. Most of the mothers tend to have the polyhydramnios because there is an obstruction in the upper esophageal segment. So this is like the X-ray like taken in a different baby who has step. In this also the coiling of the OG tube, orogastric tube in the upper esophagus is noted. The tube is not passing till the stomach. So this is also like one of the common neonatal surgical conditions presenting with respiratory distress. So these are the different types of tracheoesophageal fistula. Type A is esophageal atresia only. This is seen in 10% of the cases. Type B is esophageal atresia with proximal TEF and distal blind end, which is very rare in less than 1%. Type C is the most commonly seen TEF, esophageal atresia with the distal TEF. So this is the most common, seen in 85% of the cases. Type D is like both proximal and distal ends are communicating with the trachea, and the type E is H-type TEF. This is seen in 4% of the cases. So what are the associated anomalies of TEF? So we should rule out the like Downs, trisomy 13 and 18, Peary-Robin syndrome, DeGorge and Fanconi syndrome. And the other anomalies are we should rule out any vertebral, anorectal, cardiac, tracheal, esophageal, rectal, genitourinary and limb structure. So Vactral syndrome we should rule out, and charge related anomalies also we should rule out. The babies may also have associated anomalies like duodenal and jejunal atresia, annular pancreas, and malrotation. The most common type of TEF, as we discussed, is the type C TEF. So what are the clinical features? Drooling and aspiration, respiratory distress, cyanosis, and abdominal distension. These are the common things which are seen soon after the birth of the baby. H-type TEF presents with cough during feeds and recurrent aspiration. So this we should suspect in a baby with a similar complaints. Post-operative complications being immediate complications being anastomotic leak, risk for long gap repairs of more than 3 centimeters or 2 vertebral bodies. So the leak is common with the long gap repairs, and the delayed complications being stricture, GER, and dysmotility. So these are the complications which we should note down, and we should counsel the parents also for the same. So let us see the determinants of survival in the TEF cases. So this is determined by the birth weight of the baby and also the presence of the associated congenital heart disease. So this can be divided into 3 categories. If the birth weight is more than 1500 grams without congenital heart disease, the chances of survival are pretty good. That is more than 97%. In category 2, with babies weighing less than 1500 grams and or having congenital heart disease, any one of the condition, the chances of survival comes down to around 59%. If babies are having like both the associated factors like weight being less than 1500 grams and also associated congenital heart disease, then the chances of survival are little dismal, it's around 22%. So what is this finding on the same baby? Like post-operatively, the drain is in situ on the right side. So now post-operative day 5. So here we can see some like contrast in the stomach of the baby. So the oral contrast was given on post-operative day 5 to rule out the leak. So whenever there is no leak and the baby is otherwise fine, we can start the baby on feeds. So this is the upper GI contrast to rule out suture site leak. So we can see the drain in situ. So this is another common and interesting case. You can all see this classical X-ray. Here we can see the complete bowel loops in the left hemithorax along with the shift of the mediastinum to the right side. Even the cardiac shadow is completely shifted to the right side. So this is a case of left-sided congenital diaphragmatic hernia. So the embryology wise, this congenital diaphragmatic hernia occurs due to the deficiency of embryonic pleuroperitoneal folds at 6 to 8 weeks of gestation. Lung hypoplasia, however, is bilateral. So the common types of CDH are 85% are left-sided posterolateral, which is called the Bogdalek type, and 5% are anterior retrosternal peristernal Morgagni. So that is 10 to 15% of the cases. The incidence is around 1 in 2000 to 3000 births. This CDH can also be associated with cardiac, urogenital, chromosomal, and musculoskeletal anomalies. So it can also be associated with syndromes like trisomies and French syndrome and Turner syndrome. So what are the poor predictors of survival in CDH? Herniation of the liver is one of the poor predictive factor, and lung head ratio is generally measured at 22 to 27 weeks of gestation. It is measured as the perpendicular area of the lung contralateral to the hernia at the level of the cardiac atria, and it is divided by the biparietal diameter. So if the lung head ratio is less than 1, then it is a poor prognostic factor. The good factors are like the observed to expected lung head ratio less than 15, then it is very poor chances of survival. If it is 15 to 25%, then around 20% of chances of survival. If it is between 25 to 35%, then around 30 to 60%. If the observed to expected ratio is 36 to 45% with the liver being down in the abdominal cavity, then the chances of good survival will be there. So this we should know whenever we have a case of the CDH. So coming to the pathophysiology of the CDH, there will be a pulmonary hypoplasia, which is like both ipsilateral and contralateral, along with hypoxemic respiratory failure, and it is associated with pulmonary venous and arterial hypertension along with remodeling of the pulmonary vasculature, and biventricular dysfunction will be seen. So these babies are prone for the PPH and may need appropriate therapy soon after birth, first medical management followed by the surgical management. So delivery should be planned in a tertiary care center at term gestation. Delayed cord clamping should be done if feasible, and the baby should be intubated soon after birth. And we should avoid the bag and mask ventilation. This is one of the contraindications, CDH, for giving the ambu bag and mask. And we should monitor the pre-post ductal saturations for PPH. And we should accept pre-ductal more than 85%. Avoid high PIP more than 25 centimeters. Try low PEEP. And also HFOV if conventional ventilation fails. So there are some fetal therapies which have been done in few babies, like fetal tracheal occlusion. So, and also there was a trial, the total trial in which like done in babies. So but there was a like in babies between 27 to 29 weeks of gestational age, this therapy was done, but there was a higher risk of preterm birth with the PPROM if it is managed in such a manner. So coming to the physiology of this low PEEP, if we are delivering a high PEEP or MAP to a baby with CDH with excessive lung recruitment and INO, so here you can see that inhaled nitric oxide reaches the alveoli but cannot dilate the compressed alveolar vessels. This is because of the high PEEP which we are delivering, thereby distension of the hypoplastic alveoli. Then causes increased PVR. So with impaired venous return and preload. So the optimal will be like low PEEP or MAP with optimal lung recruitment plus INO. So this leads to increased venous return and preload. So here you can see the impaired venous return. Here venous return is optimal. And INO can also induce the pulmonary vasodilatation, which leads to decrease in the PVR. and reduced right to left ductilation. So that is why optimum PP is important in babies who develop PPHN with the CDH. So next, this is another case. In this X-ray, what we can see an inhomogeneous opacity in the right middle and lower lobes of the lungs. So this could be a case of a congenital pneumonia. So we have to evaluate and treat the same, and we have to also rule out VAP if the baby is ventilated. We have to rule out aspiration if the baby was like preterm or given feeds orally very soon and all that. So, and we also have to evaluate for congenital pneumonias. We can see we can also comment on the position of the central lines. UVC is just above the diaphragm, and UAC should be at the level of T6 to T9, and the orogastric tube should be seen in the tummy. We can also look for the other lung, cardiac border, cardiomegaly, and whether the projection is anteroposterior or posterior, and we can also comment upon the soft tissues and the about the bones here. So to complete our complete evaluation of the chest X-ray. So what we can see in this case, we can see the opacity in the right upper lobe of the lung. The baby who was extubated, um, extubated. So this is a case of right upper lobe collapse consolidation. This is the post-extubation X-ray in an extreme preterm baby. So this happens because of the more complaints of the lung. They tend to have the collapse of the bronchi, thereby leading to the right upper lobes or any other lobes. So this can be resolved by giving proper chest physiotherapy and position change frequently, along with the nebulizations which we give post extubation to prevent this kind of the complications. So this is another case and X-ray. So what we can see here, we can see some shadow above the heart in the midline, in the mediastinum. So normally neonates, like unlike pediatric and adult age group, so they tend to have this thymus, which is an organ which is usually seen till 2 years of age, which is above the cardiac border. So thymus is seen in the midline. So this is another X-ray. Here also we can see the border of the thymus just above the heart border. Sometimes in cases of the pneumomediastinum, so we can see the lifting of the thymus. So normally the thymus is described by various signs. So this is a normal variant. So these are the lifting of the thymus that is seen the sail sign. Whenever there is a pneumomediastinum, we can see the sail sign. And normally we see describe the thymus as like having the north sign and the wave sign. So these are the common terminologies that we should know whenever we are commenting about the thymus. So whenever we are taking the X-ray, so we should always try to keep the baby in a supine position and in the midline, and we should try to hold the baby, comfort the baby, and the baby should not be struggling, and preferably the one person should be wearing that lead apron, and he should be like holding the baby with hands up and legs down, so that the orientation will be central and the X-ray projection will come, and the orientation and will come properly, and the rotation will not be there, and it will be centralized. So that is how the proper X-ray should be taken. Here we can see a baby who is a 7 weeks old extreme preterm. So who was born at 27 plus 2 weeks of gestation with a birth weight of 690 grams. So initially the baby was on like ventilator, then following by extubated to NAMV, and now the baby is on CPAP and with recurrent desaturations. Baby is otherwise a well-growing baby, tolerating feeds. There were no history of feeding intolerance. But prior, there was a turbulent course with intubation, shock, needing inotropes, and the baby also was treated for PDA, had culture positive sepsis, and the baby was treated with IV antibiotics. So, what could be the reason for desaturations in a baby who is now 7 weeks old? So, that is around 33 completed weeks, 34 weeks plus now. So, the baby, if you see the lung, so this is features are suggestive of the evolving BPD. So bronchopulmonary dysplasia should be considered in babies who are uh, finding difficulty to wean out of the respiratory support with no feature suggestive of the sepsis. So coming to the radiological signs of BPD, so the stage 1 is like fine granular opacities, which are like similar to the RDS. Stage 2 is like a increased bilateral opacities, and stage 3 is like coarsening of the markings and honeycomb appearance will be seen. So the previous X-ray, the baby was having more like the stage 3 signs of PPD, and stage 4 is like coarse interstitial markings with areas of atelectasis and hyperexpansion. So here we can see the areas of atelectasis, and here we can see some areas of hyperexpansion. These are the different spectrum of radiological changes in the BPD. So this should be suspected in any baby who is otherwise growing well with having respiratory distress and approaching near to 36 weeks, where we will define the BPD in the baby. Before that, we will tell as evolving BPD. So this is a like extreme preterm case, 25 weeker with 600 grams. Baby had RDS, needed ventilation, now on NAMV. So the baby like had a difficulty in weaning out of the NAMV. Baby had previously sepsis, which was treated with a course of IV antibiotics. Baby received prolonged TPN for feeding intolerance, and also the baby followed by the baby improved out of all those problems and then had evolving BPD. The baby also needed the diuretics and postnatal steroids. So when the X-ray was taken, there was a clavicle fracture which was noted on the X-ray, and we can also see here the upper edges of the humerus. We can see the rarefaction of the bone. In normal X-rays, we do not see this like rarefaction of the bones. So then it was the cause for this is metabolic bone disease of prematurity. So the radiological signs to appear takes a long time. So initially we should start evaluating the baby like around 3 weeks of age with the bone profile. Like we will do the phosphorus, alkaline phosphatase, and sometimes calcium also to see the adequacy of these values, and then optimize them if needed. And the radiological features to occur, like it takes around 20 to 40% decrease in the mineralization of the bone. So here we can see the radiological features as well. So how to prevent this MBD? We should provide adequate nutrition, supplements, and the monitoring. Coming to the classification, which is the radiological features Coles classification. So grade 1 is the presence of bone rarefaction. Grade 2 is metaphyseal alterations with the subperiosteal bone formations, and grade 3 is the occurrence of the spontaneous fracture. So before a fracture comes or before these radiological signs come, we should have a regular monitoring and always try to prevent the MBD by avoiding this diuretics, prolonged steroids, and all those things which are prone to decrease the density of the bone, and should provide the optimal nutrition for the baby. So till now, we have seen a different spectrum of cases of respiratory distress in the neonates. So based on the history, how we will suspect. So if it's a preterm baby with incomplete antenatal steroids and having respiratory distress soon after birth, then suspect respiratory distress syndrome in the baby, and then like start the delivery room CPAP, and then do the complete evaluation for the baby. Surfactant if needed, SOS. So if there is a history of maternal diabetes and the baby was born out of LSCS and it's a term baby, and the distress is like mild and settling within a few hours after birth, then we can label it as the transient tachypnea of newborn. We can also see the features of fluid in the fissure and also apparent cardiomegaly. So that is about the TTMB. It usually settles in 1 to 2 days. So then if there was a history of prolonged rupture of membranes and intrapartum fever in the mother, then we should suspect early onset sepsis and also congenital pneumonia. Then if there was a history of oligohydramnias and chronic leak, so risk of pulmonary hypoplasia will be there, and risk of pneumothorax is there, as we have seen in the earlier case we discussed. Polyhydramnios in the mother, suspected tracheoesophageal fistula and neuromuscular disorders. Polyhydramnios, respiratory distress, cyanosis improves after intubation. Heart sounds heard on the right, suspect congenital diaphragmatic hernia. So if there was a history of fetal distress and meconium strain like that, suspect meconium aspiration syndrome, and there is a chance for the PPHN of the newborn. If there was an unexplained respiratory distress with a history of previous sibling death and consanguinity, then think about surfactant protein deficiency. If there is an instrumental delivery and post-surgery, think about the phrenic nerve palsy and look for the diaphragmatic movements on the ultrasound. If there is an acute deterioration of the baby on respiratory support, to do the DOE, rule out the displacement, tube obstruction, pneumothorax, and also the equipment failure. So, in the history, the maternal history, babies, otherwise clinical history will give us a lot of clues. So, based on that, we can diagnose what could be the cause for the respiratory distress in a particular neonate. But in our mind, we should have a differential diagnosis for different scenarios, and the X-ray helps us a lot in identifying the different cases. And the lung ultrasound is also an upcoming modality. There have been a number of studies which are comparing the X-rays with lung ultrasound so that the radiological exposure can be minimized in the neonates. So, since the chest X-ray is the basic one which is available in all centers, we should have a good understanding of the chest X-ray. Followed by, we should also try to learn the lung ultrasound and deliver the appropriate care for the neonates. Thank you for listening to the lecture, and thank you for your time.